My name is Axel Groth. I'm a medical oncologist at Mayo Clinic in Phoenix, Arizona. I'm here to discuss, as part of a roundtable discussion, optimization of late-line therapies in metastatic colorectal cancer. With me are Dr. Bekaii-Saab from the Mayo Clinic in Phoenix, Arizona, and Dr. Eric van Cutsem, providing a European perspective from Belgium Leuven. Yeah.
Thank you.
Great to have you here. So we'll talk about late-line therapies or the later-line therapies in metastatic colorectal cancer. And a lot has changed in the last 5 to 10 years. Now, Tony, this is a ball kind of passed back to you because, this really kind of is related to a trial that you led, because a randomized phase 2 trial, the REDOS study. So can you elaborate a little bit what the rationale of the study was, what the key findings are, and then I would like to get Eric's perspective on, how does that really change the way you in Europe also approach patients with regorafenib, and will it make inroads into guidelines? Tony?
Yeah, so the study emanated from the fact that, as Eric pointed out, the issues with regorafenib that happened early have led to a lot of different practices. Before the study, you and I have talked about this too. Everyone had their choice of how to start.
What's the standard dose when the package insert dose?
The package insert is 160 milligrams. This is the that came from the correct for 3 weeks in a row and a week off, and that's been the standard dose, and that's what would be considered the standard arm, at least on the study. But folks in the community, used 80, 120, stop at 120, or started with 160 and then tracked down. There was no good way to understand how, because it wasn't addressed prospectively, to understand what is the optimal dose. So the study emanated from that fact, from the need to essentially understand whether a dosing strategy that starts with 80 milligram escalates per day for a week, and then going to 120 milligrams per day for a week, and then 160 milligram, again, if there are no dose limiting or related toxicities, and a week off. So that's a dose escalation strategy. On a weekly basis, go up by 40 milligrams until you hit 160. And the standard arm, or the correct arm, was 160 milligrams, as you would do it. And so there was the comparison. The primary endpoint of the study was a very creative endpoint that essentially tried to capture the essence of efficacy and toxicity. And so it was the percent of patients who would go through 2 cycles and then are able to start the 3rd cycle. So they have to have no toxicities that would limit them from proceeding further, but also they would have to have efficacy to be able to proceed to the 3rd cycle. And the study essentially suggested that the primary endpoint of and this was, by the way, this was a superiority study. So we were looking at the dose escalation arm being superior to the standard 160 arm, and the study was positive. We're looking for a 15% difference. We found about 20% difference, favoring the dose escalation arm, which was statistically significant, going from, again, 80 to 120 to 160 on a weekly basis. So the study, in addition to the positive findings on the primary endpoint, had another surprising finding: survival. Survival seemed to favor significantly, meaningfully, trended meaningfully, although not statistically significant. The dose escalation arm, close to 9-month survival versus close to 6 months, which is what you would expect from the correct study, on the 160. Quite interesting. The arms were fairly well balanced. We couldn't find anything other than the strategy itself that could explain the differential in survival, so there was a positive finding. The toxicity seemed to favor more the dose escalation arm, not surprising. And also, when we looked at the quality of life of those patients, the quality of life did not seem to be compromised with the dose escalation strategy, seemed to be compromised at week 2, and then recorrected once the dose were adjusted on the 160 milligrams, so the standard arm.
So look at this, the REDOS study that you just talked about, the randomized phase 2, 123 patients. Well, that's kind of the filler between, we moved in the development of regorafenib from phase 1 to phase 3, and now we are redoing kind of optimization of dosing, kind of in between, which should have happened, in the way of the development. And I believe, if the 9 months could have been replicated and we had shifted, overall survival from 5 months to 9 months with regorafenib with an escalating dosing scheme in our study, Eric, we would have looked at regorafenib very differently.
Yes, that's right, and that's what we're integrating already today in also our clinical practice. And it's good that we now have these data, because until we had the data that were presented at ASCO GI, many physicians were indeed starting with 120 milligrams. Most Europeans don't start lower, don't start at 80 milligrams. We usually start at 120. But now we have the data, although being a randomized phase 2 study only, we have the data that endorses that this is a good strategy. And on top of that, there is a European academic study led by the Spanish group that is finishing now, and that will read out in the near future, later this year. Also looking at the different dosing strategy, and also with an arm of patients with 120 milligrams, not with 80 milligrams, but with 120 milligrams, so 3 pills a day. And I do believe that for patients that is the best strategy, and that's what you see also in clinical practice. Having treated a lot of patients, patients can go on with the drug for a much longer time, and that's probably the reason for the benefit, as Tony said, with this strategy.
I mean, if you see that more patients are going, almost twice as many patients are continuing treatment longer, and if you have a cytostatic agent like regorafenib, then of course, I mean, the benefit is actually quite plausible. Now, the NCCN guidelines have already kind of integrated this, as one of the options. Not yet preferred. I think, it's a phase 2, but I think people listen to that. What about in Europe? Could you consider this putting this into the ESMO guidelines?
Yeah, well, the mechanism of the ESMO guidelines is different than the NCCN. We don't update them every couple of months. But if in the previous and last published ESMO guidelines, we already say that the dosing of under 60 milligrams, the 4 tablets, that's really only for the very fit patients, and that physicians should be aware of the fact that this may lead in some patients to more excessive toxicity, and hence there is a suggestion that physicians could use the lower dose.
Yeah. No, it's interesting to talk about, the topic of our roundtable discussions, optimization of later line therapy. And sometimes it doesn't take a lot of tweaks, because, the tweaks are minor. It's pretty rapid ramp up within the first 3 weeks, of a dose. And it can lead to significant improvement. And this comes, of course, once we understand how these drugs work, limitations and the side effects, etc. So in this roundtable discussion, I think we explored real efforts to optimize later line therapies using existing agents that we have available, and from a regulatory perspective, TAS 102, and in particular, with the dosing strategies that Tony described with the readout data with regard to regorafenib, which I think toxicity management was an unmet need, is an unmet need. So I think we will hopefully see how this gets embedded into clinical practice. Thank you for listening. Hope it was interesting for you and for your clinical practice.